Good morning, class. So today we're going to be going over Chapter 17, Neurological Emergencies. So stroke is the fifth leading cause of death and the leading cause of adult disability in the United States, common in geriatric patients or older patients. Contributing factors for stroke: new treatments are available for stroke patients. Seizures and altered mental status are other common neurological emergencies. Anatomy and physiology: the brain is the body's computer. It controls breathing, speech, and all other body functions. The three major parts of the brain are going to be your brainstem, cerebellum, and cerebrum. Cerebrum is the largest part. So here you go. Little visual of the brain. So you got your cerebrum over here. Your skull, your brain stems can be right down here. Cerebellum, spinal cord. So if you ever hear of your brain herniating, it's going to be when there's too much fluid in your head, either from an injury or intracranial hemorrhage. It's actually going to push your brain down towards the brainstem. And it's being called what's brain herniation. And you guys could actually see this in someone's pupils. When I'm talking about blown pupils, one pupil is going to be bigger than the other. And it happens a lot with strokes, at least when you have a bleed or an aneurysm. The brainstem controls most basic functions. Cerebellum controls muscle and body coordination. Messages sent to and from the brain travel through nerves: 12 cranial nerves, spinal nerves. So another visualization of the brain, and then also the spinal cord. And your spinal cord is also broken into different parts as well. Many different disorders can cause brain dysfunction, can affect the patient's level of consciousness, speech, and voluntary muscle control. The brain is sensitive to changes in oxygen, glucose, and temperature. Significant changes in any one of these levels will result in a neurologic change. Sorry, class. So headache. One of the most common complaints can be a symptom of another condition or a neurologic condition of its own. Only a small percentage of headaches are caused by a serious medical condition. We'll talk about this later in the lecture. When you guys have strokes or a bleed, most likely one of the signs and symptoms is going to be a massive headache, sudden onset, what we call a thunderclap headache. It comes on suddenly and the blood vessel just bursts, and a patient complains of severe sudden onset of headache. So tension headaches caused by muscle contractions in the head and neck attributed to stress. Pain is usually described as a squeezing, dull, or as an ache. Usually do not require medical attention. Migraine headaches thought to be caused by changes in the blood vessel size in the base of the brain. Pain is usually described as pounding, throbbing, and pulsating. Often associated with nausea and vomiting, it may be preceded by visual changes. It can last for several hours, or several days. Sinus headaches caused by pressure that results from accumulated fluid in the sinuses. So serious conditions that include headache as a symptom are hemorrhagic stroke, brain tumors, and meningitis. So here's a little table showing you guys headache red flags. A patient who has a headache associated with any of the following should be evaluated for potentially life-threatening condition. Sudden onset of symptoms: explosive or thunderclap pain is going to be pretty indicative of hemorrhagic stroke. Altered mental status: anytime you have somebody with an altered mental status, have a high index of suspicion for a possible stroke. After you guys rule everything out, low blood sugar, seizure, drug overdose, anything like that. Age over 50, depressed immune system, known to be at higher risk for infection, neurologic deficits. Neck stiffness, pain, it's probably going to be meningitis most likely. Fever, changes in vision, one-sided paralysis, or weakness. So stroke, also called a cerebrovascular accident or CVA, interruption of blood flow to an area within the brain, results in the loss of brain function. Ischemic stroke, most common, accounting for more than 80% of strokes. It results from thrombosis or an embolism. Symptoms may range from nothing at all to complete paralysis. Atherosclerosis in the blood vessels is often the cause. So here's an example of an ischemic stroke. You guys have a clot right here, and it's blocking off blood flow to this part of the brain. So remember how long cells or the brain could last without oxygen before they start dying off and you're going to start having deficits. And this is an embolism that broke loose. Clot or origin from diseased or aortic valve. It breaks off and travels all the way up to the brain and gets stuck, and then starts having blocked off blood flow to that part of the brain. So most people, I would say about 60 to 70% of people who suffer an ischemic stroke, who suffer a stroke, they're going to be ischemic strokes or clot strokes. So this is why it's important to remember the very first question you want to ask in a possible stroke patient is, when was the last time a patient was seen normal? If it's within 8 hours, they have a possibility of getting a TPA or a clot blister to help break up this clot and restore oxygen to the brain. So hemorrhagic stroke counts for 13% of strokes. So it depends on which book you read. These can anywhere range from 13% to 25 to 30% of strokes. These don't happen too often, but a good indicative sign of a hemorrhagic stroke is that thunderclap headache and also a blood pressure near the 200s or over 200s. Cerebral hemorrhages are often fatal. Risk factors: Berry aneurysms are a common cause of hemorrhagic strokes in healthy young people. Presents as the worst headache of their life. Causes a subarachnoid hemorrhage. Transient ischemic stroke or TIA. When stroke-like symptoms go away on their own in less than 24 hours, the event is called a TIA. May be a warning sign of a larger stroke to come and is considered an emergency. About 1/3 of patients who have a TIA will experience a stroke soon after. All patients with the TIA should be evaluated by a physician. So any stroke-like symptoms that a patient tells you that they experience, or you see that a patient experiences while you're running your medical call, they should be transported to a stroke facility to be seen by a physician, because they do have a higher chance of actually having a CVA or a real stroke in the near future. So signs and symptoms of stroke: facial droop. So you ask a patient to smile, show me your teeth, and see if it's symmetrical or even. If one side of the face is drooping, that could be a possible stroke. Sudden weakness or numbness in the face, arm, leg, or one side of the body. Decreased or absent movement and sensation on one side of the body. Lack of muscle coordination, ataxia, or loss of balance. Sudden vision loss in one eye, blurred or double vision. So you ask a patient to raise their arms. Ask them to, like they're holding a pizza box. And ask them to close their eyes. Ask them to hold their arms up while closing their eyes. See if one arm drifts down or drops down, or they're not able to lift one arm up. That's going to be a right-sided weakness or left-sided weakness, depending on which arm it's going to be. Also, have them squeeze your hands at the same time. See if one grip's stronger than the other, if they're equal. So difficulty swallowing, decreased level of responsiveness, speech disorders. So if a patient sounds like they're slurring their speech, you could ask them if that's normal for them, or if you have bystanders on scene, family members, friends, anybody, ask them if they sound normal. And they'll be able to tell you if they sound normal or not, or if their speech is altered in some way, because that could be another sign. So difficulty expressing thoughts or inability to use the right words. Slurred speech, dysarthria, sudden and severe headache. Confusion, dizziness, weakness, combativeness, restlessness, tongue deviation, and coma. So sometimes you're going to get a severely altered patient. You're going to have a GCS of 8. You're going to come on scene and patients can be altered, unresponsive. And once you rule everything out, you get a blood sugar, get a blood pressure, get your vital signs, see if they've had any traumatic events. And then you could possibly think about calling this a stroke alert and taking the patient to a receiving stroke center. So left hemisphere, stroke in the left cerebral hemisphere may cause aphasia, inability to produce or understand speech. Strokes that affect the left side of the brain can also cause paralysis on the right side of the body. So right hemisphere, strokes that affect the right side of the brain can cause paralysis on the left side of the body. Patients can understand language and speak, but their words may be slurred. Patients may be oblivious to their problem and neglect. Patients with the problem affecting the back part of the cerebrum may neglect certain parts of their vision. Neglect and lack of pain cause many patients to delay seeking help. So right here, patients can understand language and speak, but their words may be slurred, or they may have trouble getting their words out. I had one patient who I was talking to, and he understood me, and it took him a few seconds to answer. So I had him, can you understand what I'm saying? And he just shook his head yes. And I said, are you having trouble words coming out? And he just shook his head yes. So another easy way to do that is ask them yes or no question, ask them to shake their head or nod. So bleeding in the brain. Patients may have high blood pressure. Maybe the cause of the bleeding may be caused by the bleeding as a compensatory response. A trend of increasing blood pressure is an important sign. Significant drops may occur as the patient's conditions worsen. So conditions that may mimic stroke: hypoglycemia, postictal state, subdural or epidural bleeding. Okay, so this is going to be your subdural hematoma, just right below the dura mater. So this is why you guys need to do a full assessment on every patient. You want to make sure that you rule everything out before you call a stroke alert. The number one thing that's in our protocol is we have to get a blood sugar. We have to make sure the patient's not hypoglycemic. For our county, it's anything below 70. It's going to be considered hypoglycemia. And also postictal state. So when a patient has a seizure, they have what's called a postictal state, where they kind of come around after the seizure stops. Sometimes it takes a couple minutes, sometimes it takes a little longer. It depends on the person. And then any subdural or epidural bleeding usually caused by a mechanical fall in older people. So seizures. Seizure is a neurologic episode caused by a surge of electrical activity in the brain. In the United States, it is estimated that 2 to 3 million people have epilepsy or a seizure disorder. Generalized tonic-clonic seizure results from abnormal electrical discharges from large areas of the brain. It usually involves both hemispheres, characterized by unconsciousness and a generalized severe twitching of all muscles. It lasts several minutes or longer. So some people, that's a long time to have a seizure, several minutes. Most people are going to have a seizure lasting maybe anywhere from 10 seconds to a minute. There are some people who have severe epilepsy, and they will have several minutes or longer. But several minutes or longer, it's pretty long time to have a seizure, and that could be a serious medical condition. So absent seizure does not involve any changes in motor activity, characterized by a brief lapse of consciousness in which the patient seems to stare and not respond. So partial or focal seizure, simple partial seizure, no change in the patient's level of consciousness. May have numbness, weakness, dizziness, visual changes, or unusual smells and tastes. May cause some twitching or brief paralysis, and it's usually going to be on the one side. So complex partial seizure, altered mental status, results from abnormal discharges from the temporal lobe of the brain, characterized by lip smacking, eye blinking, isolated jerking, Patients also may experience unpleasant smells or visual hallucinations, exhibit uncontrolled fear, or perform repetitive physical behavior. Aura. So patients may experience an aura prior to the seizure. So this is anything from vision changes to an unusual smell, and some patients have this. They kind of know when their seizure is about to start. So generalized seizure, characterized by sudden loss of consciousness, chaotic muscle movement and tone, and apnea. Most seizures last 3 to 5 minutes, followed by postictal state. So like I said, 3 to 5 minutes, it's a pretty long time to have a seizure. Most patients will probably only have a seizure lasting about up to a minute. So absent seizure, formerly called petit mal, lasts for seconds. Patient fully recovers with a brief lapse of memory of the event. Status epileptic. Seizures that continue every few minutes without the person regaining consciousness or last longer than 30 minutes. This is a serious condition that a patient needs to be transported probably code 3 to the hospital so the doctor could take care of them, give some medication to stop the seizures. Causes of seizures: congenital, structural, metabolic, febrile, epileptic seizures can be controlled with medications. We do run on a lot of pediatrics that have febrile seizures. So when a kid gets sick, they have a fever, and because the fever spikes or their temperature goes too high too quick, they'll have a seizure. Usually kids who are sick that have febrile seizures will not have seizures later on in life. But these are very common to go on. So here's another table, your common causes of seizures, and it breaks it down into epileptic, structural, metabolic, or febrile. There's going to be your sudden high fever, so anything that spikes pretty quickly is going to cause a febrile seizure. And then metabolic. People with low blood sugar could also have seizures, any poisoning, drug overdose, sudden withdrawal from alcohol or medications. So delirium tremens, you guys will learn about a little later on, and that's a severe sudden withdrawal from alcohol or medications that can cause seizures. And then structural, if you have a tumor in the brain, could also be pushing down on some parts of your brain and cause seizures and head traumas, strokes. The importance of recognizing seizures. Recognize when a seizure is occurring and whether this episode differs from previous ones. Identify other problems associated with the seizure. Postictal state. Following the seizure, patient's muscles relax and the breathing becomes labored. Patients may present with hemiparesis, lethargy, or confusion. If the patient's condition does not improve, consider other problems such as infection or hypoglycemia. So like I said, every time a patient's going to have a seizure, mostly tonic-clonic, they're going to have a postictal state. So it's going to take them a few minutes to kind of come around, become alert and oriented times 4 again, able to answer questions. So I would go ahead and protect the patient's head just in case the patient does have another seizure. Go ahead and throw some oxygen on the patient. Just take care of comfort measures. Reassure the patient is safe and you're doing everything to help them out because they are going to be confused. They're not going to understand what you're saying at the first. Okay, syncope. Seizures are often mistaken for syncope. Difference between seizures and syncope. Syncope is a medical term for fainting. So anytime somebody faints too, ask them if their whole body shook. People do get these confused with seizures. Altered mental status. Aside from stroke and seizure, it's the most common neurologic emergency. Common causes. Causes of AMS or altered mental status. Hypoglycemic patients can have signs and symptoms that mimic stroke and seizures. So this is why it's written in our protocols. And pretty much everywhere you go, you're going to have to get a blood sugar before you call it a stroke alert. And make sure the patient's not hypoglycemic. Delirium, a symptom, not a disease, presents as a new complaint, temporary state, often with a physical or mental cause, can be reversed with proper treatment. Signs and symptoms. Other causes of AMS: unrecognized head injury, severe intoxication, psychological disorders, medication complications, infections, particularly those involving the brain or bloodstream. So, are there any alcohol bottles nearby? Is a patient known to be a drinker? Any psychological disorders? Is a patient have Alzheimer's? Patients can be combative with Alzheimer's or dementia. Medication complications: if patient takes too much of their medications or mixes it with other medications or mixes it with alcohol, that could be another cause of altered mental status. Okay, so patient assessment: scene size up. Primary assessment: all patients with altered mental status should receive high flow oxygen. Hyperventilation may have several negative consequences. So anybody with altered mental status, yes, they're going to receive high flow oxygen. You're probably going to throw them on an armor breather at 15 liters per minute, just in case their brain isn't getting enough oxygen. History taking. Secondary assessment: vital signs. Patients with intracranial bleeding may have increased pressure compressing the brain, or possible brain herniation where the brain's going to be pushing down towards the brainstem. Can slow the pulse and cause erratic respirations. It's going to push down on the pons part of your brain and slow the pulse. Blood pressure is usually high. Changes in pupil size and reactivity indicates significant bleeding and pressure on the brain. So this is why it's a good idea to always check pupils in every patient you see, in both medical and trauma, because you could have a brain injury for either one. Check blood glucose levels. Make sure their sugar is within the correct range. So stroke assessment: Cincinnati Pre-Hospital Stroke Scale, Los Angeles Pre-Hospital Stroke Scale, 3-item stroke severity scale, fast mnemonic, Glasgow Coma Scale, GCS score. So Cincinnati stroke scale is going to be your facial droop, your arm drift, and equal grips. Okay, so it's basically a three part assessment. Your fast mnemonic is what we use. Okay, and then your reassessment. So here's your Cincinnati Pre-Hospital Stroke Scale. Facial droop: ask patient to show teeth or smile. Some patients are going to be a little shy about showing you their teeth because sometimes they don't have any teeth or they just don't want to smile. But you have to ask them to make sure that both sides of the face move equally well and one side of the face does not move as well as the other. Arm drift: ask patient close eyes and hold both arms out with palms up like you're holding a pizza box. So always tell them that pretend like you're holding a pizza box. That's when patients kind of understand how to do it. Both arms move the same or neither arm moves. Okay, so speech: ask the patient to say the sky is blue in Cincinnati. Patient uses correct words with no slurring. So. Sorry about that, class. So Los Angeles Pre-Hospital Stroke Screen. This is going to be a little more in depth right here. So this is your criteria. Age can be greater than 45. History of seizures or epilepsy absent. So you want to make sure that they don't have a history of seizures when they're not in the postictal phase. Symptoms are going to be less than 24 hours. So our last known well time, like I said, used to be 8 hours. In some places, now they're extending the deadline a little bit more. They just upped our county protocols to 20 hours. So always know when the last time the patient was done well. At baseline, patient is not wheelchair bound or bedridden. Blood glucose between 60 and 400. Again, so this is another county protocol. You want to make sure what's considered hypoglycemia in your county. Obvious asymmetry right versus left in any one of the following 3 categories. Must be unilateral or one side, so facial smile, grimace, grip, arm strength. Okay, so 3-item stroke severity scale. So your level of consciousness, normal, mild dysfunction, severe dysfunction. So 0, 1, 2, arm drift, hemiparesis. Okay. And then gaze, normal gaze. Ask the patient to follow your pen or finger to left and right sides. You guys have all seen the show Cops when they ask, when they do a sobriety test. It's the same kind of thing. Okay. So score greater than 4 indicates stroke is likely. So when you guys get to the hospital, when you have a stroke patient, the doctor's going to do a little bit more in-depth stroke assessment. And based on what they see, they're going to kind of go from there. They're also going to bring the patient back for a CT scan to see if there's a bleed or see if there's a clot. And then they're going to make a decision to either get a clot buster or send that patient in for emergency surgery. So Glasgow Coma Scale. Remember, this is what you guys need to know. So eye-opening, best verbal response, best motor response. So it's going to be a score of 4, 5, and 6, the best for each category. Okay. So you guys need to know this off the top of your head. Whenever I have a trauma patient and I'm calling in my report, they usually ask me for a GCS scale. Okay. So 13 to 15 may indicate mild dysfunction, although 15 is the score a person without neurological disabilities would receive. 9 to 12 may indicate moderate dysfunction. Score of 8 or less is indicative of severe dysfunction. So anything less than 8, you guys might have to BVM, or you guys might have to bag valve mask a patient, assist with their breathing. Their respiratory effort may be either absent or labored or shallow or inadequate. So emergency medical care. General. For suspected stroke patients, physicians and the ED need to determine whether there is bleeding in the brain. Notify the hospital regarding the last time the patient was known to be without their current signs and symptoms of stroke. So when you ask when was their last known well time, you ask them when did you see them last that was normal? What is their baseline? Is also a good thing too. What are they normally like? Do they normally know what day it is? Do they know who the president is? Do they know what month it is? Do they know what time of day it is? Anything like that. And are they normally able to walk? Are they normally able to lift their arms up without any issues? Because some people do have strokes, and when you go there, sometimes they have new symptoms, and it could be another stroke for them. So patients who have had a seizure require definitive evaluation and treatment in the hospital. Patients having a seizure, protect them from harm. So try and move anything out of the near vicinity of the patient. So any tables, chairs, put a pillow under their head. So if they have another seizure, they're not banging their head on concrete. Maintain a clear airway by suctioning. Provide oxygen as quickly as possible. If head or neck trauma is suspected, provide spinal mobilization. So emergency medical care for a headache should be concerned with the patient complains of a sudden onset severe headache, a sudden headache with fever, seizures, AMS, or following trauma, migraine. So anytime a sudden onset severe headache and also a really high blood pressure near the 200s, that could be indicative of a stroke. Or because they are having such high blood pressure, could be the cause of their headache. So make sure you guys do the stroke scale to rule that out, because they might need to get on some hypertension or blood pressure medications. So emergency medical care for stroke. Support the ABCs, airway, breathing, circulation. Provide rapid transport to a stroke center. Maintain an SpO2 level of at least 94%. Oxygen therapy is not recommended unless the patient is experiencing respiratory distress or is showing signs of hypoxia. Thrombolytic therapy and methods to mechanically remove the blood clot may reverse stroke symptoms and even stop the stroke if given within 3 to 6 hours. Or they give what's called a TPA drug or a clot buster for those who have ischemic strokes, transport to a designated stroke center, even those with TIA symptoms. So for seizures and AMS, or altered mental status, patient may be in a postictal state on your arrival. Care for patients actively seizing, altered mental status. So a review. A 41-year-old man presents with slow, irregular breathing, hypotension, dilated pupils. These signs most likely indicate dysfunction of the... So which part of the brain? So A, the brainstem is responsible for functions such as breathing, blood pressure, and pupil constriction. Brainstem dysfunction will result in abnormal findings with these functions. So the hypothalamus causes changes to occur in the heart rate, body temperature, and thirst. The cerebrum causes changes to occur in emotion, thought, touch, and movement. Cerebellum. The cerebellum causes changes to occur in muscle control, body coordination, standing, walking, and writing. An acute ischemic stroke is caused by... So remember what an ischemic stroke is. What is a hemorrhagic stroke? So is a ruptured cerebral artery an ischemic stroke, or is that a hemorrhagic stroke? Asking me a hemorrhagic stroke. Increased intracranial pressure. Usually when you guys have hemorrhagic strokes or aneurysm, that's going to cause your intracranial pressure. An acute rise in a person's blood pressure, or a blocked cerebral artery. So an ischemic stroke is going to be a clot. So a blocked cerebral artery. So D, there are two types of stroke, hemorrhagic and ischemic. A hemorrhagic stroke is caused by a ruptured cerebral artery or an aneurysm, which causes bleeding within the brain and increased intracranial pressure and possibly a brainstem or a brain herniation. An ischemic stroke is caused by a blocked cerebral artery, either from a clot that grows locally, thrombus, or that travels to the brain from another part of the body, embolus. So when older people take long plane flights and they're not moving, they're up in the air for 10, 15 hours, their blood pools down in their legs, and it could cause the blood to clot a little bit. And once they stand up, that clot could bust loose from their leg and travel all the way up either to their heart or to their head or their brain, cause a clot, heart attack, or a stroke. So a 56-year-old man experienced a sudden severe headache and then became unresponsive. He has a history of high blood pressure. The most likely cause of his condition is a So remember, a good indicative sign of a hemorrhagic stroke is a sudden severe headache or a thunderclap headache. There's going to be a hemorrhagic stroke. A, hemorrhagic strokes are typically preceded by a sudden severe headache, signals a rupture of a cerebral artery, after which a patient becomes unresponsive due to bleeding within the brain. Ischemic strokes and transient ischemic attacks generally do not cause a sudden severe headache, and migraine headaches typically do not cause a loss of consciousness. So unlike an ischemic stroke, transient ischemic attack, or TIA, is characterized by all the following except So how long do TIA attacks last for? They last less than 24 hours. So they resolve within 24 hours. They do present like a stroke, weakness, paralysis to one side of the body. They also have an acute onset of confusion and slurred speech. So anything that persists longer than 24 hours is going to be considered a stroke and not a TIA. So B, signs and symptoms of transient ischemic attack are usually identical to those of an acute ischemic stroke, e.g. hemiparesis, slurred speech, confusion, facial droop. Unlike the ischemic stroke, however, the symptoms of a TIA usually resolve within 24 hours. So this is still critical to get a patient who's experiencing any TIA-like symptoms to a stroke facility, because most likely they have a greater chance of having a stroke in the near future after having a TIA. So a patient with a suspected stroke presents with slurred speech that is difficult for you to understand. This is referred to as So remember how you guys break words down. Remember? So A is going to be without. So slurred speech that is difficult for you to understand. So they're speaking. So this means that they're not speaking at all. A without. Okay, so which one of these is going to be difficult to understand? So D, dysarthria, is defined as slurred, poorly articulated speech. It is common in stroke patients. Dysphagia is defined as difficulty speaking. Patient's speech may or may not be slurred. Aphasia is the inability to speak. Dysphagia is defined as difficulty swallowing. So dysphagia, difficulty in speaking. Dysphagia is difficulty in swallowing. And dysarthria is going to be a correct answer. Type of seizure that is characterized by severe twitching of all the body's muscles and lasts for several minutes or longer is called So remember your different types of seizures. Remember what's going to be your different signs and symptoms for each one. So D, generalized seizures are characterized by generalized severe twitching of all the body's muscles. They often last for several minutes or longer. An absent seizure is characterized by a blank stare. Generalized muscle twitching is absent. So partial seizure is broken down into simple jerking of one part of the body and complex changes in behavior and motion. Absent seizure, kind of like an absent stare. An absent seizure does not involve any changes in motor activity. Person kind of stares off into space almost. Absence or Peat-Moll seizure. Tonic-clonic seizure exhibits muscle contraction and incontinence. So the most important reason for promptly transporting a stroke patient to the hospital is because So remember, what's the reason for getting a stroke patient to the hospital within a specific time frame? They need medications to reverse the stroke. So fibrinolytic medications or clot buster, such as TPA, have been shown to reverse the symptoms of a stroke by dissolving a clot that is blocking the cerebral artery. However, for the patient to be eligible for this therapy, it must be initiated within 3 hours after the onset of symptoms. For this reason, prompt transport of the stroke patient is critical. These only work on ischemic strokes. They do not work on hemorrhagic strokes. So which of the following are components of the Cincinnati pre-hospital stroke scale? So remember there was 3 components. Remember what I talked about? What are the 3 main signs and symptoms of a patient having a stroke? Okay, so you're going to ask them to smile. Is their smile symmetrical? Is there droop on one side? Speech, how do they sound? Do they sound slurred? Are they having trouble getting words out? Or do they have trouble understanding words? And then arm drift. Tell them to hold out their arms like they're holding up a pizza box. Okay, so C, the three components of Cincinnati pre-hospital stroke scale are facial symmetry, speech, and arm drift. Both sides of the patient's face should move symmetrically, equally when he or she smiles. The patient's speech should be easily understandable and without slurring. The patient should be able to hold both arms out in front of his or her body with eyes closed and palms up without one arm drifting down to his or her side. So you're not going to... Blood pressure, yeah, that's part of your assessment, but that's not part of the Cincinnati pre-hospital stroke scale. Pupil response, also the same thing. It's part of your assessment, but not part of the scale. But it is a good indicator of seeing if a patient does have some type of bleed or aneurysm in the brain, that their pupil is blown. Okay, your patient opens his eyes when you say his name. He's making incomprehensible sounds and withdraws when you pinch his earlobe. What is his GCS score? So remember, eye, verbal, and motor. How do you guys score that? So eye is going to be 4, a total of 4. If it's a perfect score, verbal is going to be 5. And motor sense is going to be 6 for a total of 15. So the Glasgow Coma Scale gives a score of a 3 to a patient to a patient who opens his or her eyes in response to speech and incomprehensible sounds has a score of 2, and withdrawals of pain has a score of 4. When added together, this patient's GCS score is 9. So they have mild dysfunction in their brain. So this is a patient to be monitored, because anything less than 8 is going to be going downhill probably pretty quickly. Okay, so if patient complains of severe migraine, how should she be transported? So usually people with severe migraines are sensitive to light. So if the patient's not critical, I turn off the lights in the ambulance, keep it a little dim. And then with loud sirens, it's probably not going to help their migraine get much better. So, sorry, class. So patients should always be transported. You guys aren't doctors. There's only so much that you guys can do on scene, and there's only so many tools you guys have in your toolbox to figure out what's going on with the patient. So it should be transported without lights and sirens. So C, treatment of a migraine headache is supportive. However, you should always assess the patient for other signs and symptoms that might indicate a more serious condition. Applying high flow oxygen, if tolerated, may help to ease the patient's condition. When possible, provide a dark and quiet environment because patients are sensitive to light and sound. Do not use lights and sirens during transport. So remember, brightly lit ambulance. Patient's not critical, I turn off the lights. Migraine patients are sensitive to light and also to loud noises as well. I'm sure you guys have had a headache before, and listening to loud noises doesn't help. Okay. And a migraine could indicate a more serious condition. Remember, you guys aren't doctors. There's only so much you guys can do out in the field before you guys transport them to the hospital. Always offer that route. Always cover yourselves. So always transport all your patients if you can.